Hello and welcome to episode 5 of the Ask the Expert podcast series, a series featuring interviews with experts from the bleeding disorders community on the topics that matter most. I'm your host, Patrick James Lynch, and today's guest is Dr. Stephen Pipe, a pediatric hematologist out of the University of Michigan, who is also the chair of the National Hemophilia Foundation's Medical and Scientific Advisory Council, or MASAC. He joins us to discuss the major takeaways from the 2017 Congress of the International Society of Thrombosis and Hemostasis, or ISTH. That's coming up in just a moment here on episode 5 of the Ask the Expert podcast. Before focusing on today's subject, one quick update following episode 4, featuring Katie Verb from the Hemophilia Federation of America, and our conversation about the Better Care Reconciliation Act, or BCRA. At the time I'm recording this, July 20th, 2017, the bill has received opposition from numerous Republican senators and does not have the votes necessary to pass. There is, however, still an effort by supportive GOP members in the Senate and President Trump to rally the 50 votes needed to repeal and replace Obamacare with the BCRA, but those efforts appear to be on life support. So the advocacy fight is not over yet, but kudos to everyone who has called or met with their senator and voiced opposition to the BCRA and defended the Affordable Care Act. That effort is working. Now for today's interview and topic. This interview with Dr. Stephen Pipe was originally recorded for a segment on the BloodStream podcast, episode 14, but I found Dr. Pipe's contributions so insightful, timely, and well-articulated that I wanted to share it here on Ask the Expert as well. This new era of treatment that we are stepping into is an exciting one, with numerous non-factor replacement therapy products and gene therapies in phase 2 or phase 3 clinical trials. We appear to be, as Dr. Pipe puts it, on the precipice of a paradigm shift when it comes to treatment options for people with hemophilia, and perhaps most significantly, people with hemophilia and inhibitors. This interview of Dr. Pipe was recorded on July 14th, 2017, just after he returned to his home in Michigan following the ISTH Congress in Berlin, Germany. All right, Dr. Pipe, thank you very much for coming on the BloodStream podcast. Much appreciated.
Sure.
So you just got back from ISTH, very big conference, especially for clinicians, scientists, and researchers. New therapies, clinical trials, the evolving pipeline in our community is a huge topic right now. Can you just give a little, just to kick off, can you give us a little perspective on why this particular period in time is of interest to our community when it comes to therapies?
Well, I think what you're going to hear from a lot of people related to this topic is what they're calling a real paradigm shift in therapies. You know, the foundation of treatment for hemophilia has been replacement therapy for the last 50 years. And the biggest inflection point we had after the initial availability of, factor 8 and factor 9 is the real concerted effort to prophylaxis. And that's really made the biggest difference on health outcomes in hemophilia around the world, and particularly in the first world. We've had some incremental advances in the last few years. I would say mostly by improving the pharmacokinetics of the available factors. This has just given some additional tools for the treaters and for patients to try to reduce the burden of the replacement therapy, and also maybe get even a better handle on reducing breakthrough bleeding. But where we're on the cusp of is a completely different way of thinking about treatment for hemophilia. So there really isn't a single category, because the mechanisms of action here are quite different. One of the major lines of investigation is the use of a bispecific antibody called Emesizumab. This was previously known as ACE910, and this is a factor 8A mimetic. And what I'm meaning by that is one of the fundamental roles for factor 8 is to help factor 9A and factor 10 assemble on the platelet surface to drive clotting. And in that role, factor VIII really acts like a scaffold. And when factor VIII is not present, that reaction is incredibly impaired, and this is the primary defect in hemophilia A. The idea was to use the strength of technology of monoclonal antibodies, and a monoclonal antibody was designed so that one arm of the antibody recognizes factor IXA and the other arm recognizes factor X. And in a sense, what it's doing is it's replacing that scaffold function of activated factor VIII. How this is an advantage for patients is, for one, since we're no longer replacing the factor VIII molecule, we don't have to worry about inducing inhibitors in patients who are at risk for inhibitors. Secondly, if you already have an inhibitor to factor VIII, this antibody is not going to be impaired in any of its actions. So the first time we have a treatment that it doesn't matter if it's given as replacement therapy when you don't have an inhibitor or even in the presence of an inhibitor. And the third major advantage of this molecule is because it's a monoclonal antibody, it's highly bioavailability when given as a subcutaneous delivery instead of an intravenous delivery. And then the final piece is antibodies in general have a very long half-life in circulation. And so this product is showing in the late phase trials that it's providing durable bleed durable bleed protection for patients with inhibitors, patients without inhibitors, via subcutaneous delivery as infrequently as once a week to even once a month, which is being evaluated in the last phase of these trials. And what was exciting at this meeting is we saw the top-line data for the pivotal trial in individuals with hemophilia A and inhibitors who were receiving Emesizumab. And it was really remarkable, the data. Coincident with the presentation at the meeting, the publication was available in the New England Journal of Medicine. And what they did in that study, which was called Haven 1, they looked at patients who were previously with inhibitors being treated with bypassing agents, who were just taking bypassing agents on demand when they bled, and then they randomized them to either receive Emesizumab prophylaxis or to continue on with their bypassing activity on demand. And what they observed was an 87% reduction in treated bleeds with the Emesizumab prophylaxis. And maybe even more importantly, they examined the percent of patients who experienced zero bleeds over the course of the study. And 63% of the patients on Emesizumab had zero bleeds. And I think these kinds of results we've just not seen with any other intervention in adolescents and adults who have inhibitors. There was another group who came into the trial already on prophylaxis with bypassing agents. And they were also transitioned to Emesizumab prophylaxis. So now we have an opportunity to compare before they were on Emesizumab and after, both in a prophylactic setting. And again, we saw an almost 80% reduction in treated bleeds when transitioning to Emesizumab. And in their secondary endpoints, looking at all bleeds, joint bleeds, spontaneous bleeds, target joint bleeds, overall 80 to 95% reduction in those bleeding events. So as this study was being presented, I think people were really excited about these results and really hoping that this will continue to move forward in the regulatory path. Now, as with all things, these studies also are not just evaluating efficacy, but they're also evaluating safety. And this trial was not without some significant high-profile safety concerns. So the idea of a bispecific antibody driving a coagulation reaction with very long half-life, people, even going into this trial, did have concerns about whether there would be any untoward effects like thrombotic events. As it turns out, there were 5 events over the course of the trial. 2 were essentially a deep venous thrombosis complication, and 3 patients had an unusual complication, which is a thrombotic microangiopathy. This is an unusual type of sort of hyperclotability in the blood that can be marked by destruction of red cells and platelets. So as they examined these 5 events, they were trying to look for what was the commonality that was observed amongst these patients, because the vast majority of patients did not have these complications. And what seems to be a unifying theme across these 5 events is these patients were all being treated for some breakthrough bleeding in the course of the trial, and they were using bypassing therapy on top of the Emesizumab. Now, lots of patients still had bleeds in the trial and treated without consequence with their bypassing agent of choice, whether that was FIBA or Nova-7. But when they dove deeper into the clinical scenario of these patients, what they noted is patients who were treated with high doses per day, more than 100 units per kilo per day, on average for more than 24 hours of treatment were the ones where this complication was seen. So that allowed them to introduce some risk mitigation strategy for the ongoing portion of the trial, and the recommendation was that doses of the bypassing agent should be reduced, and if possible, patients had a history of having a reasonable efficacy with Nova-7. It was suggested to maybe try Nova-7 instead of the activated prothrombin complex concentrate, or FIBA. So we don't know the full extent of the follow-up since that risk mitigation strategy was introduced, but the anticipation is that hopefully this will be a reasonable approach to avoid this complication in the future. So that was really the first high-level event that was presented. The second one is we also have some interim data from the Haven 2 trial, which was for hemophilia A patients with inhibitors who were less than age 12. And the patients in this trial range from age 2 up to just less than age 12. And we only have data on 20 patients, and these 20 patients had at least 12 weeks of follow-up over the course of the study. And I think what was really remarkable is there were no bleeding events in these 20 patients over that course of follow-up. There may have been one bleed that was treated, if I remember from the platform presentation, but essentially the rest of the patients experienced no bleeding. I think any of us who treat patients with inhibitors, this is a remarkable achievement for a prophylactic therapy. And more importantly, in this population of patients, there were no thrombotic complications as well. This second platform presentation received considerable enthusiasm, and we'll have to wait a little bit longer for the full results from this pediatric pivotal trial. But from what it sounds like, with the conclusion of these trials, they will have sufficient data to finish their filing with the FDA for review for possible commercialization for patients with inhibitors.
And between now and then, is there any particular data point or piece of information that you will be looking for as the trial proceeds?
Well, I think if I was a reviewer for this application, I would want to see clearly from the time they introduced the risk mitigation, has there been any additional subsequent thrombotic complications? And if not, then that would give the regulators, again, in my opinion, would give the regulators an opportunity to put that same risk mitigation strategy into the label to ensure when this, is approved, that clinicians and patients clearly understand, the high efficacy that it potentially has, but also how to use it safely and hopefully avoid any further thrombotic complications. Now, I also think in a study of this size, we have to be careful and put things in perspective. There's no way in the course of a small clinical trial like this that you can accommodate every possible clinical scenario that a patient might encounter. So, for instance, none of these patients, as far as I'm aware from the presentation, went through any major surgery. Think like a hip replacement or a knee replacement, something along those lines. I'm not aware of any patients who had, a major traumatic event. And thirdly, we'd be concerned about things like sepsis and perhaps, what's the role of indwelling catheters, etc. So I think when this product has the potential to expand to much larger swath of the population, I think due diligence going forward is important. And almost certainly this product's going to require some data collection in the post-marketing phase so that we can track how, what's happening in patients in a number of clinical scenarios.
And if things continue to proceed with Emesizumab and the trials and the Haven trials as expected, when's a ballpark timeline for when we may see this product available in the United States?
Well, I think it was well known that the FDA had granted a sort of a rapid review status for this product, and I would imagine that would give an opportunity for hopefully a priority review. And, based on where this trial is currently, I think there's a good possibility that a review could be completed before the end of 2017.
So you mentioned at the beginning how for the last 50 years or so, factor replacement therapy has been the standard of care, and Emesizumab is an example of a non-factor replacement therapy that is getting closer and closer to potentially entering the scene in a major way. Can you give us an overview of maybe a couple other non-factor replacement therapies or gene therapies that are being worked on that you are paying particular attention to?
Yeah, so the other series of presentations that I think were also very interesting is the work with Fitusiran. So Fitusiran is, again, a completely different way of thinking about treating hemophilia. So first let me just give an analogy to help people understand. So I want you to picture a teeter-totter. And on one side, you have the procoagulants. So this would include factor VIII, factor IX, the things that are driving clotting. And then what's counterbalancing those procoagulants are natural anticoagulants. And there's three natural anticoagulant pathways that we know are of particular significance in controlling this clotting and bleeding balance. One is called tissue factor pathway inhibitor, or TFPI. The other one is antithrombin, and then the third one is protein C. And when you have a reduction in the procoagulants, the hemostatic balance is tipped towards bleeding because you have the full action of the natural anticoagulants and not enough procoagulants. So what we've been doing for 50 years is adding back in the procoagulants to try to bring the teeter-totter back into balance. But it's actually been known for some time that you can accomplish the same thing by not replacing the procoagulants, the clotting factors, but actually reducing the action of the natural anticoagulants. And how do we know that this is true? Well, we've known for some time that individuals who inherit so-called thrombophilic risk factors can actually moderate the clinical phenotype of severe hemophilia A. And in fact, there's some studies that have shown that if you have co-inherited something like protein C deficiency, or there's even some examples of co-inheriting antithrombin deficiency, that this improves the thrombin generation in these individuals, even though you haven't added back in any factor VIII or factor IX. So I think we already had some clinical experience to suggest this is likely to work. So Fitusiran uses a technology to knock down the synthesis and the protein levels in the blood of antithrombin. And it uses a technology that actually resulted in a Nobel Prize for the individuals who came up with this strategy. It uses what's called a small interfering RNA. So these RNAs are synthesized to target a very specific gene sequence. What they did is they modified this RNA so that it would specifically target to the liver. And they did that by adding essentially a sugar group onto the RNA so that it would be recognized by the scavenger receptors that are on the liver, which are sampling the plasma as it goes by. And this SINR gets taken up by the cell, and it delivers this small interfering RNA to the nucleus. And what it does is it specifically seeks out the messenger RNA coming off the gene for antithrombin, and it assembles in a complex, which is called the RNA-induced suppression complex. And what it does is it actually ends up cleaving the message from antithrombin so that antithrombin deficiency goes down. And depending on the dose it's delivered, you can suppress the protein levels of antithrombin down to about 20% or less of normal. And so again, what that does is it changes the balance. And so now without giving any factor VIII or factor IX, you're allowing the teeter-totter to come into balance. And it may seem incredible to think that you could prevent bleeding without providing any factor VIII or factor IX replacement, but that's exactly what the studies have shown. They showed a dose-dependent, durable suppression of antithrombin to down to about 20% of normal. Notably, this is also given subcutaneously. And in the study that was presented at ISTH, this was dosed as infrequently as monthly. And they showed what happens to the thrombin generation in these patients. And it turns out that, again, without replacing any factor VIII or factor IX, their thrombin generation starts to approach and even overlap with healthy controls who do not have hemophilia. And then the proof is really in the bleed control. And again, what the study showed is the patients who went on prophylaxis with this Fitusiran were able to get durable bleed control with Q-monthly subcutaneous dosing. Individuals who came into this trial, their median annualized bleed rate was about 12 per year, and if they were treated on demand. And a couple of patients were on prophylaxis and already had low bleeding rates, as you can imagine, with an annualized bleed rate of about 2. And both of those groups were followed with prophylaxis with Fitusiran, stopping their regular replacement therapy. And the annualized bleed rate on Fitusiran was 1.7. And that data I just gave you is for patients who had inhibitors. They also included individuals who didn't have an inhibitor. And this was a fairly heavy bleeding group that came into this. They were on-demand patients, and their annualized bleed rate before Fitusiran was 38, and the median annualized bleed rate on Fitusiran was remarkably 0. Now there's a range in there, but the median at least was 0. So again, very exciting data. Again, as we talked about with Emesizumab, the study's also evaluating safety. So were there any safety issues in this trial? Well, there were no thromboembolic events in this study, and no clinical laboratory evidence of any pathologic clots formed. The treaters were instructed to reduce the use of bypassing agents or factor replacement while patients were on the trial. So they had already implemented a risk mitigation strategy was built into the trial. So that seems to be successful as far as preventing thrombotic events. What they did observe is they had several patients who developed a modest elevation in their liver enzymes. That got as high as about 3 times the upper limit of normal. They were completely asymptomatic. They were only picked up on laboratory assays. Most of the cases improved without any dose interruption. In one case, the patient did discontinue the drug. Not sure what the mechanism is causing this, although, again, looking for a unifying underlying factor in these patients. All the patients who had this liver enzyme elevation were positive for hepatitis C. So it's possible that this is somehow directly or indirectly related to their underlying hepatitis C status. So pretty remarkable study results. This paper also came out in the New England Journal the same day it was presented at the meeting. So 2 really paradigm-shifting therapies, top-line data from pivotal trials, and the expectation is for presumably a drive towards imminent regulatory review.
And just to cap off Fitusiran, similar final questions as we discussed with Emesizumab. Are there any particular data points or anything that you are going to be keeping an eye out for as the study continues? And timeline, when might we, Fitusiran's in a different point in its progress than Emesizumab, when might we see that product on the market?
I believe Fitusiran still has a phase 3 trial program, or so-called pivotal trial program, which will continue to execute over the course of the second half of this year. So I would imagine that, we're going to be well into 2018 before this may be approved. As far as what I would be looking for, I think, people are interested in this transient elevation in the liver enzymes. If it is true that this is limited to hepatitis C patients, I think we want to see over a larger population of patients if that's true, and then maybe try to understand what type of hepatitis C status was precipitating this. I don't believe any of these patients actually had active disease, but we'll have to see if there's a particular subgroup of these patients who, maybe this is going to have to be watched closely once they first start on the drug.
And moving from these 2 disruptive or breakout therapies to the gene therapy world, what in the gene therapy realm is of interest to you? Any updates at ISTH that were of particular note, or anything that you've read that's particularly encouraging or indicative in some way?
Yes, we saw a number of again, top-line results from the gene therapy trials. Now, there's nothing really new that hadn't been previously presented at either the WFH meeting last summer or the at the ASH meeting this past December. But what we did get is sort of some additional sort of follow-up from the patients who were reported in those trials, and I think the 2 programs that received the most attention with new results at ISTH was the SPARK study using a bioengineered AAV vector with a hyperactive factor 9, so-called Padua variant factor 9, and these subjects have now demonstrated that they've had durable expression of factor 9 activity that's been somewhere between 20 to as high as approximately 75%. So thinking back to what we were sort of expecting from the clinical trials with gene therapy, I think people were looking to convert patients from severe to maybe moderate or mild disease, but this program suggesting with a hyperactive form of factor 9, you can push patients so that they're approaching or actually in the normal range. The other trial that was had some additional follow-up study was the study from BioMarin, which is the only one that we have data for Hemophilia A. This is again an adeno-associated virus, or AAV. It was a different serotype or viral coat, if you like. This was an AAV5 vector. But at the highest dose cohorts, again, remarkably, the majority of patients were within the normal range for factor VIII, so above 50%, and a couple of patients actually got to supernormal levels, above 150%. No complications from expressing that high, but now what was presented at the meeting is that these patients have durable expression, and they're still showing stable factor VIII levels in this curative range. So I think this has just really raised the bar for what people are anticipating from gene therapy. Now, these were all early phase studies, phase 1 level data. Many of the companies are moving on to their phase 3 studies, both for factor IX and for factor VIII. And I'm just really excited going forward that, this could be the final transition that we've been looking for in hemophilia. And, I think the subjects that have been evaluated are all in adults. I think it'll be some time before we see a pediatric trial for gene therapy. But, I think you've got real hope here that, look, we're probably still going to do replacement therapy in our youngest patients. It's possible if they develop an inhibitor, we may still do a trial of immune tolerance, but we're probably not going to do immune tolerance for years and years, in a state of futility. When you've got potential therapies that will work for inhibitors and provide prophylactic, bleed prevention, I think we won't continue with immune tolerance regimens indefinitely. And then maybe these therapies these emerging non-IV therapies will carry patients to adulthood, preserve their joints, and they will then have the option to consider gene therapy when they're an adult. And so what the paradigm shift here is it's not a complete abandonment of factor VIII or factor IX replacement, but overcoming some of the major challenges that have been before us. Being able to have an effective therapy for inhibitors, so that it wouldn't remain the scourge and the real cost to care that it has been for so many years, and therapies that are really cross-segment, if you like. Fitusiran, it really doesn't matter whether you have factor VIII or factor IX deficiency. It doesn't matter whether you have an inhibitor or not an inhibitor. In fact, it hasn't been explored yet, but there's all the reason to think that this agent would work for any clotting factor deficiency. So think factor VII deficiency, factor X deficiency, etc. And so maybe that will be explored, and maybe we've opened up an avenue to provide the kind of prophylactic therapy that's needed for some of these other rare bleeding disorders. So I think this has never been a more exciting time to be working in hemophilia, to see the fruits of really innovative research come all the way to the clinic and be executed successfully in these clinical trials. I just think is tremendously exciting.
I know I have to let you go, so just one more question. We've heard, again, you said it earlier, for 50 years, factor replacement therapy or replacement therapy has been the standard of care. In the last number of years, extended half-life products, still factor replacement therapy, but extended half-life products were kind of the big development and the big discussion amongst community in terms of new therapies. As we move into this potential, as you said, final transition, what is the role of factor going forward?
Well, we didn't really talk about it yet, but, there's a lot of things that we've got used to doing in managing patients with traditional factor replacement, which are not going to be available to us with these new agents. So the first thing is we have clinical correlates from a factor level and a clinical outcome. These new agents don't really give us the kind of clinical, like measurable laboratory tests that we're used to then provide the kind of clinical correlates that we've developed and learned over many, many years. And so that creates a little bit of anxiety and uncertainty in the treaters. If you're trying to get someone set up for, just think like a hip replacement surgery. How are we going to know with these new agents how to get them through that surgery? Have we given enough? Is the clotting action of these drugs really good enough to get the patients through those surgeries? What about a major trauma? What about a CNS bleed, a head bleed? I think there's a lot of things that we've learned to manage very well with factor replacement that we are going to be sort of starting from scratch, if you like, with these new agents. So I think we want to continue to make sure that we've got factor replacement for those times when we actually need it. I don't know that these agents have been fully evaluated with really intense peak activities. So think about the soccer player, the basketball player, or even the older patient with hemophilia who wants to go on a camping trip with his grandkids. Is he going to be able to rely fully on these new therapies for those kinds of peak bleeding risk events? And I think we need to let that unfold. I think factor replacement is going to be with us for some time to come.
Well, thank you again for basically getting off the plane and being willing to take this call and provide this information. Really interesting stuff, and it's certainly an exciting time in our community. So thanks for helping provide perspective and helping us understand where exactly we are and what we should be paying attention to.
Yeah, my pleasure.
Looking forward to doing it again. Thank you, Dr. Pipe.
Bye-bye.
Bye-bye. I want to once again thank Dr. Pipe for making time to discuss this very important topic with me immediately following his international flight home. Very generous of him to give of his time that way, and not just for me, but for all of you, the community. If you're curious to learn more about the updates and information that came out of ISTH, to learn more about some of the things Dr. Pipe had to say, check out the program notes for this episode in your podcast player or at bloodstreamexpert.com, where you will find links to several articles that we here at Bloodstream Media thought you might be interested in on the heels of ISTH. And that is all for episode 5 of the Ask the Expert podcast series. We will be back next month with another expert interview. Don't forget to subscribe to the Ask the Expert podcast, the Powering Through podcast, the BloodStream podcast, and the Bloodline podcast on iTunes, Stitcher, or wherever you listen to podcasts. Or visit bloodstreammedia.com to stream or subscribe to all of Bloodstream Media's podcasts for the bleeding disorders community. Have an idea for a future episode of Ask the Expert? Email us at mailbag@bloodstreammedia.com. You'll also find Bloodstream on Facebook, facebook.com/bloodstreammedia, and on Twitter @bloodstreaminfo. This episode of Ask the Expert was written by Patrick James Lynch, produced by Patrick James Lynch, Rob Bradford, Andrew Gall, Josh Bragg, Avra Friedman, and Colby Crow, and the Ask the Expert podcast is edited by Mr. Andrew Gall. I'm your host, Patrick James Lynch, and until next time, take self-care of yourself.